Hello, my name's Tim Child and I'm Medical Director of Oxford Fertility and Associate Professor at the University of Oxford. And thank you for the opportunity to present our RCT to you, a randomized controlled blinded trial assessing the effectiveness of embryo glue as an embryo transfer medium in IVF cycles. I was hoping to be able to attend the ASRM to present to you in person, but US visa requirements mean that from Europe, we can't travel until November. So back in 2015-16, there was a lot of interest in the use of add-ons and how perhaps they're being missold by fertility clinics with the claims of increasing the live birth rate per cycle. The Human Fertilisation and Embryology Authority, or the HFEA, which is the UK's government regulator for fertility treatments and embryo research, brought in a traffic light system to look at add-ons with green, amber or red, dependent on the quality or the presence of RCTs to showing an improvement in live birth rate with the use of add-ons. And you can see there's a list of add-ons here. And down the left-hand side, we have hyaluronate enriched medium, i.e. embryo glue, which currently is rated as an amber, as in there is some evidence suggesting benefit. So we decided back in 2016 to look at this more closely and to undertake a large RCT. So we wanted to determine if the use of embryo glue as an embryo transfer medium results in higher live birth rates in IVF cycles when compared with standard embryo transfer medium. We undertook a power calculation based on previous published data, and we wanted to see if we could get a 10% increase in live birth rate from our base rate in all patients overall of 32% up to 42% per cycle. And that showed we needed 730 women being randomized. The physician, the nurse, and the patient were blinded to allocation, sealed, numbered envelopes were used, and we recruited at our single center between 2017 and 19. The study was funded by our center. There was no external funding at all. And the study sponsor was the University of Oxford, and the trial was registered before commencing with clinicaltrials.gov. And Research Ethics Committee approval was gained from the NHS. The inclusion criteria were women undergoing fresh or frozen transfer and aged between 18 and 45 years. Exclusion criteria: planned freeze-all of embryos, the use of donor gametes or endometrial scratch, if patients were participating in another trial, or if they had previously been randomized into the study, or if they were planning to use embryo glue anyway. For patients having fresh IVF, we used a long or short protocol with Gonal-F and or Menopur, conventional IVF or ICSI depending on sperm quality, and embryos were cultured individually in sage one-step under sage oil in conventional benchtop or time-lapse incubators. In frozen cycles, patients either had a natural or a medicated. In a natural frozen, we use no trigger or no hormone supplementation at all. And in the medicated, we use estrogen 6 milligrams, and then we add in vaginal progesterone 600 milligrams. Patients were consented and randomized by the lab when the lab were arranging the embryo transfer day and time. So it's normally 2 or 3 days before the ET day. In terms of the study, before embryo transfer, in the study group, embryos were placed in 1 ml of pre-warmed, pre-equilibrated embryo glue for between 10 and 30 minutes in keeping with manufacturer's guidelines. And the HA concentration is 0.5 milligrams per ml in embryo glue. In the control group, embryos were placed in 1 ml of pre-warmed, pre-equilibrated sage one-step, and the HA concentration is less than 0.125 milligrams per ml. And from a Cochrane review, they consider no or low to be less than 0.125. At embryo transfer, either 1 or 2 cleavage stage embryos or blastocysts, depending on embryo quality, patient history, and our multiple birth minimization strategy, were transferred back to the woman's uterus using a Wallace-Sherview catheter under scan guidance. As mentioned, this was blinded to patient, physician, and nurse. Unblinded could only occur with cycle outcome, i.e. with a negative test, a miscarriage, or live birth. And in both fresh and frozen cycles, we used vaginal progesterone 600 milligrams. No patients used intramuscular progesterone. So first part of the results, 731 patients were randomized. So we met our power calculation. In group A, that was 364. In group B, which is embryo glue, 367. There were some dropouts on both sides, about the same number. In about a third of the dropouts, it was because of concerns over the risk of OHSS and therefore a freeze-all. In about a third, it was because of concerns over endometrial quality. And in about a third, it was because patients had changed their mind and wanted to leave the study, usually because they wanted to have embryo glue anyway. And the average age was the same in both groups. Now, the main part of the research outcomes are shown here. Again, the primary outcome was live birth. On an intention to treat basis, i.e. randomization, you can see there was no difference in the live birth rate with control, 37.5, or with embryo glue, 35.7%. Per protocol, i.e. those who had embryo transfer, again, no difference, 45% live birth rate compared to 38.2%, so not statistically significantly different. Then when we start to look at the data more closely, patients who just had day 5 transfer, about the same number in both groups, again, no difference. Just day 3, no difference. Day 3 live birth rate is lower because these are poorer quality embryos. That's why we're transferring on day 3. Patients who had single embryo transfer, which was about 2/3 of the patients, about a 42 to 45% live birth rate per embryo put back, not different between the groups. Double embryo transfer, again, not different. It's a lower success rate because these are poorer quality or older patients. Just looking at fresh transfer, again, no difference. Frozen transfer, no difference. So for frozen cycles, we were getting a 45 to 48% live birth rate in natural or medicated with the use of 600 milligrams of vaginal progesterone. Just want to make that point. The multiple birth rate was less than 10% in both groups. Clinical pregnancy, which was defined as heartbeat on scan, again, was good in both groups and no different. And the miscarriage rate, again, was low in both groups. This was miscarriage after having seen a fetal heart at 6 to 7 weeks on scan. So essentially, there was no difference, no increase in the live birth rate in this randomized trial with the use of embryo glue at embryo transfer compared to standard media. However, a Cochrane review almost exactly a year ago looked at this same question as well. And the Cochrane review looked at the live birth rate with high, such as embryo glue, versus low or no hyaluronic acid, i.e. such as our control group, and did suggest an increase in the live birth rate with a relative ratio of 1.2 and statistically significant because the confidence intervals did not cross 1. They also suggested a trend towards a lower miscarriage rate, but the quality of the studies was very poor. They suggested a higher clinical pregnancy rate, a higher multiple birth rate as well. And this is the forest plot from that Cochrane Review 2020. And these are the trials that have been listed. So you'll notice the lozenge here on the right side with the odds ratio of 1.2, not crossing unity, i.e. statistically significant. However, as they point out in Cochrane, 4 of these studies the numbers are purely based on abstracts. These have not been published yet in peer-reviewed press. So Cochrane also looked to see what happens if these 4 studies that have only been published in abstract form, not peer-reviewed, are taken out. If you do that, the risk ratio for live birth is now 1.13, and the confidence intervals hit 1, which means that it is no longer statistically significant. So as you are aware, while systematic reviews and Cochrane reviews are very powerful, it all comes down to what papers you decide to put in or not include. However, if we go back to the original Cochrane review, including all of these studies, and we add in our own study, this is the Oxford 2021 study, with a risk ratio for live birth with the use of embryo glue of 0.95, it's not statistically significant because the confidence intervals cross 1. You'll see that then recalculating the overall Cochrane live birth rate, the risk ratio for the use of embryo-rich, of hyaluronic acid-rich culture media is not as strong as it was before. It was 1.21, now it's 1.16, but it is still statistically significant. Again, though, if you remove those 4 unpublished studies, there is no evidence of benefit for the use of compounds that are rich in HA, such as embryo glue. So therefore, in conclusion, our appropriately powered and undertaken RCT showed no improvement in live birth rate with the use of an HA rich embryo transfer medium such as embryo glue compared to standard media. There was no difference in clinical pregnancy or miscarriage rates. Importantly, embryo glue was used as per the manufacturer's advice, in particular the 10 to 30 minute culture time. If we add our trial results to the Cochrane review, it does not change the overall conclusion of the Cochrane review, but that completely depends on which trials are selected. And my last line really is, I think, a challenging question. What do we do if we are working in clinics? We've undertaken our own RCT suggesting no benefit of the use of, for instance, embryo glue, but that is at odds with larger published data sets. What do we do under those circumstances? And I wish I was there to be able to discuss that with you. Thank you very much.